So my first talk is Preschool Wheeze. I have no conflict of interest. The aim of the presentation will be to discuss a practical initial approach to Preschool Wheeze, and most of these children will require no tests. I'm going to review the implications of the Lancet Commission for the preschool years and look at personalizing treatment. And I'm going to discuss the roles of leukotriene receptor antagonists, macrolides, and prednisolone. And I will also end by showing that preschool wheeze has implications for life. So firstly, is there a specific diagnosis to be made? Coughs and wheezes fall into one of 5 categories which you need to do from your history and examination. The first is normal child, the most difficult diagnosis of all. The second is a serious illness, which is rare but essential to get right. The next is an asthma syndrome. The next are minor problems such as rhinitis or reflux, which may mimic or worsen wheeze. And finally, the over-anxious parents. All that wheezes is not asthma. You must take a good history and a detailed examination. In the community, isolated dry cough is rarely, if ever, due to asthma. And we overdiagnose and overtreat cough variant asthma, at least in England. Investigations should be targeted. If any, most children will not need any investigations. So, normal cough includes the prolonged post-viral or bronchiolitic cough. 10% of children have at least 10 viral colds a year with symptoms for at least 2 weeks. Many children have at least 3 episodes of otitis media. And we are seeing a resurgence of pertussis in the United Kingdom. Nursery school syndrome is usually a first child. Early placement in a childcare facility in a creche. Repeated viral infections, one viral cold merging into another, and it responds to no treatments because, of course, these are normal colds. And so my prescription is a soothing drink of honey for the child and a glass of good wine for the mother, both to be repeated. In the history, you should ask, is it really wheeze? Because in my country, the word wheeze is used for many different sounds. Are there prominent upper airway symptoms? Are there symptoms from the very first day of life? The sudden onset of symptoms suggestive of a foreign body? A chronic wet cough and phlegm for more than 4 to 6 weeks? Is the child worse after meals? Irritable, arching away, vomiting, suggesting reflux? Are there signs of a systemic illness or immunodeficiency? Or continuous unremitting symptoms? This child here has repeated short bursts of symptoms. This one has a more prolonged cough but gets better. But this one, getting worse and worse and worse, is the one to worry about. On the physical examination, look for digital clubbing. Pediatricians are very bad at doing that. Weight loss, failure to thrive. Look for upper airway disease. Here you can see a nasal polyp, typical of cystic fibrosis. If there's an unusually severe chest wall deformity, think of another condition. And if there are abnormal signs with the stethoscope, think again. And of course, look for signs of cardiac or systemic disease. Is personalized medicine practical in preschool wheeze? And this is one of the things from the Lancet Commission. We wanted to suggest we should personalize airway disease. what did we mean? So what is this thing called asthma? Is it airway inflammation, variable airflow obstruction, bronchial hyperresponsiveness? A doctor said so. I once got given an inhaler, or what is it? No, asthma is an umbrella term for wheeze, chest tightness, dyspnea, and cough, just as anemia means a low hemoglobin, arthritis, hot red joints. You need to ask, what sort of asthma do I have? What do I mean by this? Well, first of all, does the child have fixed and variable airflow obstruction, including airway instability? And if they do, if they have bronchodilator responsiveness, they should get beta-2 agonists. Does the child have airway inflammation? Specifically, is there airway eosinophilia? If so, prescribe inhaled steroids. Is there airway infection and or impaired host defenses? In which case, prescribe antibiotics. And this was done for years by the late Freddie Hargreave. So why would we want to treat preschool wheeze? To try to prevent disease progression to asthma in school age, or to treat symptoms. And I shall discuss some of these possibilities. The first and most important thing is that early use of inhaled steroids are not disease modifying. So here, the Peak study, and from Manchester, the IFWIN study, in both cases, inhaled steroids were given to preschool wheezers very early on, and in neither case did it stop them progressing to atopic eosinophilic asthma. And the same from Denmark, when intermittent steroids, just given at the time of wheeze, no prevention of progression. And indeed in Manchester, those who got treated with inhaled steroids actually long-term had worse airflow obstruction. So what are the role of inhaled steroids? Well, in this study, many years ahead of its time, continuous inhaled steroids failed to prevent acute wheeze with virus infection in preschool children. In this American study, intermittent montelukast and intermittent nebulized budesonide were better than standard treatment. I should say I do not use nebulized budesonide. It was used by the Americans because it's the only steroid licensed in the preschool era. Here they used intermittent fluticasone in this huge dose, which caused side effects, and it reduced prednisolone requirement. And here a comparison between intermittent and continuous steroids, no difference. But this study, the infant study, is really very interesting. 300 preschool children. They were each given in random order daily inhaled steroids, daily leukotriene receptor antagonist, and as needed inhaled steroids. They used a composite outcome of asthma control days and time to an attack requiring steroids, and they pre-specified they would analyze by subgroups of aeroallergen sensitization, gender, and wheeze attacks. Many of these children, 60 of them, got better, and you can see that the ones who did best in the whole group were with daily inhaled steroids. They were much less likely to have an asthma attack. And if they then divided by whether they were aeroallergen sensitized or not, again, the daily inhaled steroids was much more effective in those aeroallergen sensitized. They also looked at blood eosinophil count, and you can see that if they had a blood eosinophil count of more than 300, they were more likely to react to inhaled steroids favorably. whereas low blood eosinophils, it didn't matter what you gave them. And if you combined eosinophil count and aeroallergen sensitization, the group who did well with inhaled steroids were those who were sensitized and had a raised blood eosinophil count. And this was the first attempt at personalized medicine in preschool children. What about leukotriene receptor antagonists? Well, we know that cystinyl leukotrienes are raised acutely in viral wheeze, and parents probably do not want to give medicines to well children. The PREEMPT study initially seemed to show that intermittent montelukast was a good treatment for preschool viral wheeze. I have shown you this before, that intermittent montelukast in this American study seemed to work. However, in this huge study of nearly 1,700 children, intermittent montelukast and daily montelukast was no better than placebo. And in Jonathan Griggs' weight study, again, nearly 1,400 children, no effect of montelukast. So at best, montelukast is a medication that works only for a very few children. So what about, how do we treat children with episodic problems? The first choice would be a bronchodilator if they need treatment at all. I do try leukotriene receptor antagonists, but they usually don't work. The next is intermittent inhaled steroids in a dose of no more than 400 micrograms of becotide a day. And otherwise, combinations of the above. But these remain very difficult to treat. If they're having multiple trigger wheeze, step one, and I'm going to give a blind trial. Step one is to commence high-dose inhaled steroids for 6 weeks. Is the child symptomatically improved? If the answer is no, think of alternative diagnoses and therapies. If the child is better, you stop the treatment, because you don't know whether the child's got better because of the treatment or because the child was going to get better anyway. If the symptoms do not recur, then no further action is needed. If they do recur, you titrate the dose of beclomethasone to the lowest dose to control symptoms. And by this means, you will not overtreat children who are getting better anyway. What about management of acute wheeze attacks? What about the antibiotic azithromycin? There have been 3 papers. In this paper, asthma-like episodes lasting at least 3 days in Copenhagen, randomized to azithromycin or placebo, and you can see the blue line, azithromycin, shortened symptom duration. Note, incidentally, that a number of 20% of children had symptoms for about 3 weeks. If treatment was started early, the effect was much more beneficial. They didn't report bacterial cultures, and they didn't have an ordinary antibiotic limb because, as we know, azithromycin has numerous anti-inflammatory effects. The next study from America, over 600 children who had to have previously been prescribed at least 1 course of prednisolone, randomized to azithromycin or placebo, and the primary endpoint was prescription of oral steroids. And you can see here the adjusted cumulative risk of progression for the azithromycin group in black was better than those who did not have azithromycin, but the effect is small. However, the third trial, the biggest of all, nearly 1,500 children in accident and emergency, randomized to azithromycin or placebo, absolutely no benefit. And you can see here days to resolution of symptoms, placebo, azithromycin, absolutely the same. And again, you can see here, time to the next attack and the exacerbation of the disease, absolutely no difference, and no subgroup effects. So what does this mean? The benefits of azithromycin are highly questionable in very mild disease. There's evidence of some benefit in children with previous acute wheeze. It may be justifiable in those with really acute severe wheeze who may be going to intensive care, but should not be a routine medication for acute preschool wheeze. And of course, you have to worry about the effects of azithromycin resistance in the community. What about prednisolone? This is a meta-analysis, nearly 2,000 children in 11 studies. Overall, no benefit on admissions. There was actually no benefit at all if you were an outpatient. A small benefit for an emergency room, but basically, as you can see, for hospital admissions, no benefit of steroids. If anything, steroids made you worse as an outpatient. A very small effect if you're in the emergency department. Further results, you can see for all comers, giving steroids did not mean you got less steroids later on, except if you're an inpatient. But overall, most children had no benefit, most preschool children no benefit. You only need to give steroids if the child's in hospital, and possibly a hint that the sicker patients may benefit. And the mechanism is not clear. So this was a study published in the Lancet Respiratory Medicine, and they said 600 patients, mean saving of time in hospital 170 minutes. Interestingly, the identical design, almost the same, a bigger study, exactly the same time saving, not significant. I do not think this Lancet study is very good. They changed the design halfway through. When the primary hypothesis was disproved, they then decided to do another analysis, which you can't do, and particularly without blinding it. And what would the parents say? 170 minutes more in the hospital, or a 3 to 5 day course of steroids? So prednisolone is not a community medication, not a routine secondary care medication, possibly for multiple trigger wheeze with a really severe attack, and possibly any severe wheeze heading for intensive care. Finally, what does it mean in the long term? So here you can see in red from the Manchester cohort, boys and girls the dotted line. The red line are children who are getting progressively worse airflow obstruction, and it's in those who have multiple allergen sensitization and acute severe wheeze. And what happens next? I showed you how the lung function is getting worse. Well, now if you look at these 3 birth cohorts, they showed 4 trajectories of lung function. And basically what I want you to appreciate is that the lung function at 5 determined the lung function at 16. And the risk for persistently low was early and acute severe wheeze, early allergen sensitization, tobacco exposure, and ongoing wheeze and asthma. And you can see if you're exposed, if you have a persistently high trajectory, these are the ones who are least likely to be exposed to tobacco at home. The genetic analysis was largely negative. So this is the Melbourne birth cohort, recruited at age 7, followed to age 50. And at age 50, they looked at non-asthmatic, they rephenotyped into non-asthma, current asthma, remitted asthma, and COPD, and tracked back the lung function. And what you can see is those patients who had COPD age 50 had the worst lung function at age 10 years. And if you had severe asthma, the signal was even stronger than smoking. So preschool wheeze and deteriorating lung function has implications for the rest of your life. But what about beyond the airway? Are there other effects? So in this study, they measured spirometry in 3 different cohorts, and of the 111 of 161 in FOC, 338 in cardia, 71 in Gen 3 had a low FEV1, less than 80%, and they followed them up. And what they showed was, as well as if you had a low FEV1, as well as having more respiratory morbidity and mortality, you had worse cardiovascular and metabolic morbidity and mortality. The same was shown in cardia, the same was shown in Gen 3. So a low FEV1 is a marker for all-cause bad outcome. There was a higher all-cause mortality, independent of, but additive to smoking. And interestingly, there was a strong genetic effect. If both parents have normal FEV1s, your chance of having a normal is 97%. You're going to be very normal. There was a strong relationship between parental and offspring FEV1. So a bad FEV1 means more than just bad airways. So what are my take-home messages from this talk? Firstly, remember that there may be a specific diagnosis to make. Think, what is the diagnosis? We should be exploring the use of blood eosinophil count and aeroallergen sensitization to personalize inhaled steroid treatment. If medication is not working, don't persist with it. Prednisolone and Azithromycin should solely be given to children with really severe acute wheeze. And remember the long-term consequences. The preschool child who is wheezing may well be going on to have more COPD and more cardiovascular and metabolic consequences. So thank you for listening, and I end with a picture of my grandchildren. Thank you very much.